Hello, I'm Zainab Badawi. Welcome from London. It's my great pleasure to be moderating this seminar in this year's Policy Centre for the New South in their Atlantic Dialogues. And we're discussing the wider Atlantic in a challenging recovery, of course, because of COVID-19. And what we're going to be discussing in this particular seminar is public health imperatives in the global South. And I'm very pleased that we've got three excellent speakers representing three very important regions of the global South: Africa, Latin America, and also Asia. And I'm going to ask each of our speakers to make some opening comments. Then we're going to bash around some of the ideas that they've raised in their opening remarks. And please do use the chat function and send us your Q&A as soon as you hear something that you want clarified, or whether indeed it's a comment that you want to make. And I will do my best to incorporate that in our discussions. So needless to say, COVID-19 has put the spotlight on pandemic preparedness and how we can build robust health systems, not only to deal with the current emergency, but also to ensure that we can prevent and deal with the next one. And that involves a myriad of things that have to be done at national and local level. And that's what we want to explore in this session. So let's have our first speaker, Natalie Della Palm, great friend of mine. Lovely to see you, Natalie, as always. And she is CEO of the Mo Ibrahim Foundation. It's a foundation which is dedicated to putting governance at the heart of everything that is done in terms of trying to make Africa a better continent for its people. And of course, building robust health systems is very fundamental to that. So Natalie, when you look at Africa's population, 1.3 billion or so, I believe there have been around 5 million deaths. There are obviously more cases than that due to COVID-19. And we've heard a great deal about no one is safe until everyone is safe in terms of getting the vaccine out. We've heard strong expressions like vaccine apartheid, because something like 0.3% of the vaccines have been distributed in Africa. So just give us an overview and your opening remarks on the situation as you see it, and how you would answer the question of public health imperatives in Africa. Thanks, Natalie.
Well, thanks to you. Thanks, Zainab. Thank you very much. I think that the African continent, specifically on the African continent, COVID impact has indeed laid bare the vulnerabilities of the public health system and the challenges that need to be addressed. Many thought that the African continent was more immune to the virus, maybe thanks to a younger demography, a warmer climate, and certainly, and this needs to be underlined, an earlier prevention and containment measures than anywhere else, thanks to previous pandemic experience, noticeably Ebola lately. But however, I think that we must be aware that numbers are still rising on the continent. And to be frank, we cannot consider the data as fully reliable. And this is a first, I would say, public health imperative, because civil registration system weakness is a key vulnerability on the continent. You only have 8 countries that have a decent death registration system, which means that in Africa, only 10% of deaths are registered. In which case, I think it's difficult to accurately measure casualties. We only have 4 countries that have a reliable birth registration system, meaning that currently half African children have no legal existence, in which case it's very difficult to ensure any efficient vaccination campaign or public health policy. But even if indeed the pandemic toll is milder than in other regions, it has really starkly laid bare Africa's health system vulnerabilities. There is only 135 beds on average, hospital beds for 100,000 people. There is only 2 doctors for 10,000 people in sub-Saharan Africa. In sub-Saharan Africa, only 28% of health facilities have access to reliable electricity. And last but not least, the vaccine supply has absolutely underscored Africa's unsustainable overdependencies to external supply. Indeed, Africa currently represents probably 25% of vaccine demand, and it imports its vaccine supply for 99.9%, which is obviously unsustainable. Now, why is that so? Much progress has been made, undoubtedly, since early 2000, but demographic trends are running quicker than economic growth, and whatever progress is made, it's never enough to answer the demand. But I would say that the second point is key, and it's probably an over-reliance on external aid, be it multilateral, bilateral, or philanthropy, be it Gates Foundation or Red Crescent. But it underlines the fact that probably for African governments, health is not a domestic priority. There is insufficient ownership and political commitment to public health policy. More than 20 years ago in Abuja, African heads of state had committed to commit at least 15% of their budget to health. Up to now, none have met that commitment. So it's really something that is unsustainable. Now, what must be done? What can be done? Definitely recover, build, and boost Africa's health autonomy and sovereignty, if only because it's a matter of security. I think it's useless to talk about post-COVID recovery if Africa doesn't become safe from the virus and its ever-multiplying virulence. If Africa were to become a variant incubator, it will be totally shut off from the outside world. I think we must be aware of that. Now, first, of course, we need to boost Africa's vaccination rate. This is a challenge that calls for international community effort, not only through commitments, but through implementation of those commitments. And we all know that this is still lagging behind a little bit. We have a current situation where Africa's population full vaccination rate barely reaches 6.8%, while Europe's population rate is 68%. This is not only unacceptable from an equity viewpoint, it's also totally inefficient. It means sharing doses, stop hoarding them, but also boosting the logistics to make sure to get shots into arms. But also, and this is key, really consider health as a key public policy priority, not one that can be delegated to private commitment or donors' aid. If I line up very quickly these different priorities, it's providing universal health coverage, which is an ambition which is both in the SDGs and in African Union Agenda 2063. Currently, it's only 10 African countries that provide universal health coverage. Allow for better working conditions and professional mobility of health workers and experts, strengthen health infrastructure, and very important, because security lies at heart of health sector. And we all know that Africa has not a very good track record when it comes to counterfeit medicines. Strengthen quality control and governance on the African continent when it comes to that sector. Last but not least, there is absolutely a priority to build a vaccine manufacturing capacity to be prepared for the next pandemic, which will absolutely arrive, but also to provide for current vaccines in Africa, which demand will continue to grow with rising demography. Once again, the market is there, 25% of global demand. It is a business case and it can provide local employment. So you talked at the beginning, Zainab, and this is the center of our meeting. It is a challenging recovery. Many people, and rightly so, and at the Mo Ibrahim Foundation, we've worked on that. We had a very important debate last June. We all consider today that the current crisis can be a huge opportunity to, as everybody says, build back better. But we are also absolutely convinced that there will be no recovery no progress in economic and social development if health security is not achieved. So this is really a challenge that needs to be overcome. Thank you.
Thank you so much indeed there, Natalie. You've given us a lot and we will come back to it in terms of what the outside world needs to do, and also rightly calling for African governments to really meet their commitments to their long-standing promise or goal to spend 15% of their own budgets on healthcare to meet universal health coverage. Thank you. Let's turn now to Latin America, South America, and go to you, Sergio Suchodolski, CEO of the Development Bank of Minas Gerais in Brazil. Lovely to see you there. I hope the weather's behaving in Brazil for you. It's very nice here in London, Sergio. So, Sergio, Brazil has been in the news a great deal in terms of COVID, obviously, with the comments of President Bolsonaro that have been seen to perhaps not have taken the COVID pandemic as seriously as he might have. I think your deaths so far recorded are in the region of about 600,000, population of over 200 million in Brazil. So make what you want of that. But give us an idea of how you in Brazil see this picture, both in responding to the immediate demands of tackling the COVID pandemic, but also what kind of health imperatives and gaps in your system it's shown up and what you can do about it. And if there's anything that you heard Natalie say that you want to respond to in your comments, please do. Thanks, Sergio.
Thank you very much, Zainab. Good afternoon, ladies and gentlemen. It's a pleasure to join you today from Brazil. It's also a great joy and honor to once again take part in the Atlantic Dialogues, such a lovely event. And we very much miss being in Marrakesh. Maybe next year, I hope so. In any case, I would like also to salute Natalie and Nilan, our fellow panelists, and also a special thank to Karim El-Nui and all the team of the Policy Center. I'm a CEO of a subnational development bank and also the president of the Brazilian Development Association, which gathers 31 development finance institutions around Brazil. The development finance institutions have played a very key role all around the world, not only in Brazil, in Latin America, but also in other regions of the world related to the health sector for a long time. That unfolds in projects very early stage, such as the financing of the COVID vaccines. One particular example that we should reference is the European Investment Bank early stage financing of the BioNTech company, which allowed for the development of the COVID vaccine. We have seen other development banks financing respirators, hospitals, and all kinds of health-related projects or items that were very key and still are very key in fighting the pandemic. In Brazil, we have no doubt faced very dire moments, especially in 2020, before we were able to secure at scale the production or the imports of vaccines. At this stage, although the death toll is very high and higher than most Brazilians would have liked it, and this is due to the fact that we had a delay in the importation and the celebration of contracts. We have 2 laboratories that are domestically located that have signed joint ventures with international producers. And also we started importation at scale in the past 6 months. So this allowed us to be at a point now where we are no longer a hot spot. We have a national health system that has the capillarity, and this has been used in the past for the outbreaks of other pandemics in the country and the large vaccination mile once they have the vaccines. So we're very happy at this point to be announcing, especially last week, we had the first day without any deaths in the state of São Paulo, and also the first day without any deaths in the state of Rio de Janeiro just 2 days ago. So it's a very comforting news for us after a very long winter, let's call it this way, and very tragic in terms of the number of deaths. I should mention on the other side, relating to the work that we do, very early on in March 2020 at the Development Bank of Minas Gerais, we launched our first emergency program. And this emergency program was targeted at 31 different subsectors of the health spectrum. So that means we started financing and increased financing for hospitals and clinics. We increased financing for COVID tests and all related products in the treatment of COVID. And this was very key in benefiting more than 20,000 patients, more than 4,000 health workers, and the production of over 500,000 COVID tests and 17,000 components for mechanic ventilators, which are very key for the treatment of the cases that are more complicated. In terms of the general view of our bank, we are aligned with the 2030 agenda of the Sustainable Development Goals, and we see the long-term benefits of investing in the health sector for the economy and, of course, for the welfare of our good people in the regions where we operate in 7 different states of Brazil. So we would like to conclude our remarks by saying that the idea of investing in the public health systems and closing their financial gap is more than an ethical imperative, but also an effective development pathway that emerging countries should rely upon. And the development banks certainly are ready to do their part in this major effort. Thank you very much, Zainab.
Thank you so much indeed, Sergio. We'll come back to you, particularly on that question of investment in the health sector. I'd like to pick up something myself on that, and I'm sure Natalie would too. But let's first of all hear from our third speaker today. Neelam Adio is director and co-founder of Gateway House, India. And Neelam, that I believe is the Indian Council on Global Relations. I think you set it up around 2009, and it's essentially a foreign policy think tank looking at India's role in the world. And so if you could unmute yourself, Neelam, and share with us your thoughts. Again, I think India has attracted a lot of attention, of course, because it's the home of the Serum Institute, which is the world's biggest vaccine manufacturer. And of course, you've been working in partnership at the Serum Institute with AstraZeneca to produce vaccines which have been distributed all over the world. But just give us your opening thoughts, please, about the public health imperatives in the Global South from your perspective. Thank you.
So thank you very much, Zainab. I want to thank the Policy Institute for inviting me. And I do want to apologize. I'm in the United States and we got the timing all mixed up. And so I've come on late and maybe looking a little bit more ruffled than I normally would. But thank you very much for your patience. So yes, I would like to just share a few facts about the Indian experience, which has always give a very mixed and ambiguous in some ways picture. First of all, India has now administered more than 1 billion doses, and something like 42% of the population above 18 years of age is vaccinated with 2 doses. Another 39% or so has received 1 dose. So it's actually a quite successful high rate. And that is because of the Serum Institute of India, which is the largest producer of vaccines in the world. But it has also, of course, contributed to some of the problems in India. in Africa, because when we were hit by the second wave, the Delta variant, in fact, we actually discontinued the supply of vaccines to COVAX, and they were unable to fulfill their commitments in Africa and in some of the other developing countries. So fortunately, that phase has now been passed and the exports have resumed. So I hope the situation in Africa will be ameliorated along with all the other actions that African countries have taken collectively and separately. The success rate of vaccination in India owes itself almost entirely to two features. One is, of course, the extensive digitalization of the population. Almost everyone in India now has a smartphone and a bank account. And therefore, the government put in place a program called CoWIN, on which people could register directly, or if they are illiterate and don't know how to use it for registration, assistance was provided for that purpose. This system, after a few initial glitches, has worked very well. And everyone that has had vaccinations has also received certification of those vaccinations. The second and maybe even more important factor in some ways is what we call ASHAs. These are women, rural women, accredited social workers who have gone literally from house to house to motivate people and assist them in accessing the vaccinations. And that is why we do have a fairly high rate of people who have had some coverage. These women, this program was initially set up more than 20 years ago, and the purpose was maternal and child health, and that also contributed to the fact and is part of the massive vaccination systems that the government of India has put in place for polio, for smallpox, for other vaccinations for infants and small children. That experience, with assistance from some international foundations, including the Ford Foundation, the Bill and Melinda Gates Foundation, etc., has proved very helpful in this process. But as I said, it's also been a mixed bag because of the problems it created for some time in other developing countries by curtailing the supply. And I will want to just make a very brief mention for that reason. Democracy, which we all love to praise, actually became a little bit of a problem. The opposition got up and opposed very loudly the export of any of those vaccinations which had been committed and contracted, and some even paid for earlier. And the government was forced to curtail those exports. Everybody needs to get re-elected, but there has to be a better way to do this. Now, at that time, nobody wanted to consider the supply chain issues because the vaccinations that are produced in India also depend upon supplies from the United States, which curtailed all exports in the production of vaccines, as well as from other countries for APIs, etc. So I think we have to look at all of these issues as well, which brings me to the second point I want to make, which is that the multilateral system does seem to have failed. It took the WHO almost 3 months before it declared a global pandemic. Those 3 months were lost, and a lot could have perhaps been done in that period. The UN Security Council was unable to meet and discuss the problem early last year because China has a veto, and it was being alleged that the source of the pandemic lay in Wuhan, China. That's another failure because the UN Security Council did take up earlier cases of SARS and actually many countries dealt with HIV as a national security issue. The third institution which has failed and continues to fail us is, of course, the WTO. People in Africa will recall that HIV killed such an extraordinary number of young people, particularly in South Africa. until South Africa and an Indian company, pharmaceutical company, Cipla, decided to ignore the IPR, the intellectual property rights regulations, and produced the cocktail that helped to bring down the numbers of those. Maybe that is something that the developing countries need to look at now. South Africa and India put in an application with the WTO 1 year ago after the vaccines had been produced by some companies. And that application has only just begun to be discussed, despite the fact that 90 countries, principally developing countries, have all supported this application. Even the United States announced support for the waiver of IPR regulations so that more vaccines could be produced in other developing countries. It's also really unconscionable that the medications to be administered in early stage vaccinations to vulnerable groups are priced at something like $700 for one course. That's not something that people or governments in developing countries are going to be able to pay. I think developing countries need to have a more cooperative position on this. One final issue that I want to mention is COP20. And COP20 is being celebrated as some form of a success. In fact, it's not a great success. We understand from science that a lot of new viruses might get released as the permafrost melts. Developing countries are being asked to bear a burden beyond their capacities. Rich developed countries, and I'm only going to mention a statement that former Senator Kerry, who represents the United States, has gone back after COP20 and said that, next year when countries meet, there's going to be a review of their nationally determined commitments. That does not mean that the United States has to make more commitments. So I think this sums up for me the attitude that developed and rich countries have taken. They have not fulfilled their commitments on climate change, and they have not made very generous commitments. And even when they've been made, they haven't been fulfilled in the problems relating to COVID. At the same time, the group of 7 and the group of 20 have both met. They have both expressed unhappiness at what happened, at what has been happening with COVID. But the commitments are really, I want to just read out the statement that the G7 made to conclude. And this is in inverted commas. We, the leaders of the G7, met in Cornwall 11th to 13th June 2021, determined to beat COVID-19 and build back better. We remembered everyone who has been lost to the pandemic and paid tribute to those still striving to overcome it. Close. But where is the assistance? Where are the commitments that we need in developing countries? Thank you.
Thank you very much indeed for your very robust views there, Neelam. And let me pick up something straight away with you, because Natalie at the beginning also mentioned the fact that Africa is only home to less than 0.1% of vaccine production facilities and relies on outsiders to provide them with their vaccines. You've talked about the fact that you want to suspend patents on COVID-19, but you know what the arguments are. People like Angela Merkel in Germany says, I would be against giving away patents because the solution, that's not the solution. If a patent is given away, the quality is no longer controlled. You'll see markets flooded with counterfeit drugs and so on. So are you seeking a suspension of the patents for drugs that, cure illnesses such as COVID-19, or why can't you support the granting of licenses, which is something which is a bit different, which is what the Serum Institute in India has done with AstraZeneca. It is producing it in partnership through this granting of a license. Would that be sufficient, or am I just splitting hairs?
I do not want to pretend to know a great deal about the actual manufacture, but I do want to say that in a once in 100 years emergency that we are in right now, I think we need more than nuanced and sophisticated argumentation. Licensing, yes, great. And the Serum Institute, of course, has been able to step up supplies because it sought this license even before AstraZeneca had actually produced the vaccine. It takes time to set up all of those facilities and the expansion of those facilities. I think what I'm trying to say is that we are actually looking at a world in which there are likely to be more such viruses. We need a system where we can all act together much more rapidly and save lives. You know, by any estimate, anywhere between 5 and 17 million people have already died. The numbers of deaths in a lot of countries are not actually going down even yet.
All right. Okay, maybe you can all take your microphones off mute. I just wanted to throw this question to you because in building robust health systems, you've all agreed, and we'll look beyond the pandemic in a minute, but you've all said that pandemic preparedness is very important. Natalie, you said there'll be another pandemic around the corner, and the area of the world you're very interested in, of course, it's Africa, 16% of the global population, but it's where 70% of pathogens with pandemic potential emerge. And so, you know, there are a lot of infectious diseases that will emerge in Africa. So on this question of vaccines, we've seen the European Union say, we support plans to produce COVID vaccines in Egypt, Senegal, Rwanda, South Africa, but we're not supporting patent waivers. Giving the license is what we'll do. Is that sufficient for Africa to become more prepared for pandemics, producing vaccines in that way?
I can see Nila's point. I mean, but I think that indeed it's not the only solution. And I think that indeed license is already quite important, because if indeed we want to and we need to boost Africa's manufacturing capacity, we do need, as you underlined yourself, to make sure of the environment. And first of all, the governance and the regulation and the quality control is absolutely key. Once again, Africa, sadly so, is known as being very bad when it comes to counterfeit drugs. So the installation of the Africa Medicine Agency is a priority, as is a priority the brain drain challenge, because we have a lot of health workers and specifically health researchers that are African, but they are working outside the continent. So we need at the Africa level to find the ways to get them back and to attract them back to work for their own country. We also need to solve the basic infrastructure challenge, access to reliable energy. You can't have a current and efficient vaccine manufacturing capacity if you don't have reliable electricity. I think the potential is there. There is already 10 potential hubs in Africa: Egypt, Kenya, South Africa, Nigeria, Morocco, Tunisia. So the beginning is there. But if we want indeed to be able to produce vaccine in Africa, we need to begin now. So we need now to deal both with the current vaccine distribution challenge and to build this vaccine manufacturing. So Nila, I agree with you on these patents, and I can see your point. But if we only solve that patent point, it would not be enough. So let us make sure that while we are trying to solve that patent license challenge, we solve all the others. Otherwise, it will be lost. And this is, I think, Angela Merkel's point, and to be frank, EU's point.
Yes, they support the licensing. Thank you. And you make a very good point there. And I should remind anybody listening to this that, of course, the African Union target is for Africa to supply up to 60% of its routine vaccines by 2040, which is not that long away. And we're still very dismally far off that. Sergio, you talked about the fact that in Brazil, you produced in partnership the COVID vaccines that you needed. Perhaps just tell us a little bit more about your experiences there in Brazil and whether there are lessons for the rest of the global South.
No doubt. Thank you, Zainab. And it's difficult for me also to talk about COVID without bearing in mind other challenges in the health sector that we have faced in the past and the creative solutions that we were able to come up with, including partnerships between Brazil, Africa, and other regions of the world. And by that, I reference to the AIDS joint effort 20 years ago. Brazil led a coalition of countries that were making pressure on some of the manufacturers to share the intellectual property with public labs around the world that could produce at scale and for a cheaper price. So I'm not advocating we should not respect the intellectual property rights and all the investments and the incentives for the investments that are necessary to develop new solutions and especially new vaccines and treatments for the health challenges that we face. But we need to look at developing countries, especially the least developed and the ones that are more fragile from a different perspective, because these pandemics, they are like a boomerang. We are not isolated. If we are not able to manage the situation in different countries, we will see the pandemics coming back as they are coming back in many regions, including in Austria that just started a new lockdown and in other areas of the world. So the challenges are global, and we need to collaborate in a more effective way. In terms of Brazil, what we see today is we had one state of Brazil that very early on started a joint venture with Sinovac from China and was able to produce at scale already in the mid-2020 vaccines. And actually myself, I got shots from the Chinese Brazilian corporation, the most population here. We have achieved now 60% of the population, Brazilian population, having both doses or at least or one of the one dose vaccines, and 79% of the population had at least one shot. We've been seeing increase of procurement from the federal government from some sources, and we have 2 Brazilian vaccines. So these are new vaccines that are being developed in Brazil by universities and public labs that are in the final stages of testing. So this is definitely a tribute that we should pay to these health researchers and health workers that have been funded by government and by the private sector in the past, and that are now almost ready to deliver at scale for the next year new vaccines produced in Brazil that could be exported to other countries and creating a larger array of available solutions for the pandemic. So what I'm advocating here is that we could reinforce the capabilities and the geographic establishment of laboratories that are able to cater to the necessities of every region of the world. And the Global South should be definitely developing its own capabilities.
That's very, very important. Thank you. So don't look always to, the European Union or North America or whatever in terms of being prepared for the next pandemic. So I think we've looked at the essentials there of pandemic preparedness. We've identified where the holes are. I think diagnostics, testing in the first place, having the right data in place, as Natalie said at the outset, is very important. Therapeutics, we know that there are oxygen shortages and ventilators and all the rest of it in lower income countries. Actually, also in the more developed countries too, I think their systems were lacking. And then this issue of vaccines, the three kind of planks, the diagnostics, therapeutics, and the vaccines. So just looking at, so pandemic preparedness, I think we've dealt with that properly. Let's look at, ambitions to meet universal health coverage. And of course, that's a very important health imperative in the global south, because of course, not everybody does enjoy that. Natalie brought up a very important issue, which is this issue of health personnel. There's no point having the equipment and the drugs and so on if there's nobody there to administer it and knows what they're doing with it. And we've seen nurses, doctors, paramedics going from the global south to work in the global north. And this is really depleting health systems and compromising efforts to achieve UHC. So let me throw that particular question open to all of you. Natalie, you raised it. You might want to come back with a response on that. Just what do you do about that? Because freedom of movement, of course, if a doctor gets a chance to work abroad, they may leave. Why not?
No, but I mean, I certainly think it's a key topic. I mean, you currently have more Ghanaian doctors working in UK than working in Ghana. You have more Senegalese doctors working in France than in Senegal. So it's really a huge issue for the African continent. But I think it's also an issue that, for me, should be seen as a mobility challenge and not a migration challenge. And this is certainly a conversation to be had between Europe and Africa in the oncoming summit, which is, rather than being afraid of migration, loss of people on one side, too many people on the other side, think about this way to strengthen mobility, to answer the varying demand and to see how supply can do that. On the other side, if indeed we want to see African health workers coming back to work on their own continent, in their own country, we come back to this initial question of infrastructure. They need to have the means to work properly in their own hospitals, in their own cities, in their own countries. So it's a holistic policy, public policy to put in place. And this is, I think, very important. But it is a challenge.
Yeah. We'll come to the holistic challenge in a minute, but just on this issue of health personnel, I mean, Neelam, in India, you've got a lot of doctors working here in the UK who are originally from India. Sergio, in Brazil, you've got a lot of people who move and work in Portugal and other parts of the world. So do you want to make a comment on this issue of health personnel, the mobility of health personnel, and how the global south educates and trains people who then go and take their skills elsewhere? It's the global south and the global north. Yeah, Neelam.
Very briefly, I just want to say that we have had this big debate on people trained and educated in India, doctors principally, but also engineers and others, many of whom migrated to the global north, to the United States, UK, etc. We had this big debate in the 70s and 80s, and the government tried to put in measures, including penalties, for when you join a medical college, you undertake to pay back the cost of that education, etc. None of it worked very well because we have not very strong state capacities. But by now, I think maybe the solution for us was that a very large number of new medical colleges were put in place and engineering institutions. And so the numbers of employees is no longer a problem in India. So we have enough doctors, enough nurses, enough engineers. The quality is an issue very often because many of these new institutions, or at least some of them, are fly-by-night and they don't actually produce very well. The other thing that may have helped a little bit is more focus on indigenous systems of medicine like Ayurveda. But I do want to add one problem to the one that Natalie adds about the whole holistic infrastructure. And that is that governments are actually, especially in India, less than 2% of the budget is meant for health purposes in India. And that includes the whole setup, including those wonderful ASHA workers I mentioned at the beginning, who are so underpaid. It's unbelievable. We really need to spend more on the public health systems, and we need to recognize that medicine is only one part of it. In India, the whole hospital system is being privatized, and so the middle and the upper middle classes and the rich are able to access excellent healthcare, but people, the rest of the country and the majority of the country, still not middle class, are just being left to their own devices. We need to have some other way to do this better. And just for the vaccines, I want to mention, you know, Moderna received billions of dollars from the US government to produce their vaccination. Today, they are in a big fight for IPR protections and do not want those privileges to be extended even to the government scientists who worked with them to produce the vaccine. IPR has to be re-examined.
Thank you. Sergio, on this issue of health personnel, then I'll come back to the kind of holistic approach that both Natalie and Neelam have touched on.
Thank you, Zainab. I think this is a very pressing issue for us in Brazil as well, a little bit different from Africa. We have had experiences also in bringing foreign doctors to Brazil. In recent years, we had an agreement with the government of Cuba not very long ago, where Cuban doctors would come to Brazil and service areas that were underserved. This is an experience that which has mixed reviews. Most of the Cuban doctors went back home, and there was a huge debate around how the Cuban doctors were being paid. Most of their salaries were actually paid back to Havana, and that created a major controversy. So they were not really earning their full salary, which created a huge debate in Brazil. On one side, financing of the government in Havana, the other side, the need that we had for doctors, especially in regions that were underserved, and therefore we had the presence of doctors, and of course a positive situation for the local population. But I think this needs to be dealt also in a more holistic way. What we've been seeing and the pandemic to reach out and provide more sophisticated tests even to regions that are underserved. So what I believe is that we need to find cooperations. We need to find cooperation between the North and the South. We need to understand that we live in one world, and that if we don't take care of those that are underserved, this will hit us back. It's very clear. It will hit us back because people travel around, because we have migration, as you have said, because the viruses, the bacteria, they don't stick to borders or any kind of frontiers or any kind of conventions that we might have set up. So either we understand that these are common goals, that we have to work together and create the incentives of those who are developing and investing. I don't think that that is a specific issue. What the specific issue is that we have regions that need to have a different kind of approach, and we need to develop some kind of solutions, subsidies, philanthropic, large institutions should play a role, and in some cases we should find through the WTO, through the international organizations, waivers in very specific and in cases of emergencies, especially the ones that we are living in today.
Yeah, sure. Okay, and it's something that you've all raised really, and maybe let's just look at it a bit more. I mean, it's so obvious that you think to yourself, why are we even discussing it? But it is very obvious in trying to provide universal health coverage and building, robust and resilient health systems in countries. You can't look at health in isolation. You've got to look at, as Natalie said, an energy policy. How are you going to keep hospitals running? Equipment is often, needs power to really operate. So, power is relevant, good infrastructure, good roads, good water and sanitation provision. These are all components of the Sustainable Development Goals. So in a sense, they all rise and fall together. So in building resilient health systems, how far do you think governments are really focused on the fact that actually it's right across all government bodies and departments that you have to tackle health imperatives? Whoever wants to start on that one. Natalie, sure.
Yeah, I would start because I think it's a very important point you just raised, Zainab. Health is not about aid. It's not about emergency or about even humanitarian policy, whatever. First and foremost, if the population is not healthy, there is no need to think about education, business, and whatever. Second, health is an economic sector. So everything that's done to develop the economic sector means businesses and local employment. So I think that for this reason only, it must be a priority for any government. And once again, as Nila said when she was saying 4% of public expenditure in India, is what we have seen in Africa. Not enough public commitment and public expenditure in the health sector. It must be seen as a priority, and as a priority because it has a huge economic and social impact. So really this is something that must be upgraded in the government's priorities, and not just be left however they can help, of course, and however they are welcomed, but not just be left to international community, multilateral institutions, development banks, and other philanthropies. It's also a matter of sovereignty. It's a matter of security. And I think this is probably one of the main lessons for Africa of this COVID impact. They have realized how far too much dependent they were on outside supply. And they have, at political level, we've seen that at African Union meetings, at the Africa CDC meetings, and at private sector level, there has been a huge unknown before commitment, both at political and private sector level, in this health sector. So I'm not pessimistic, but I think we must keep the drive and not consider that it's just a crisis that's going to be met and then everything will be forgotten. Thank you.
Thank you, Natalie, for your closing thoughts there. And Sergio, let me ask you to incorporate your response to the fact that it is so obvious that we need this holistic approach when we're talking about dealing with health challenges, and to incorporate your closing points.
Yes, I would join and agree with Natalie in her remarks that the health sector is an economic sector, right? And we need to look at it from all kinds of incentives, and including the jobs that are created, as she's well mentioned. Just bringing a specific figure that I think it's very revealing. According to the World Health Organization, central governments only provide on average 51% of the total healthcare expenditures, and in most of them, the level of the per capita expenditure fall below the threshold required for an adequate provision of healthcare services. So in this sense, closing the financial gap for the health is an urgent matter. It's not a matter of the current crisis of this specific pandemics. We have other diseases, even diseases that were extinguished and that are coming back. As in some countries, TB is coming back. In Brazil, TB had been extinguished, and now it's coming back very strongly. I believe that for sure the public development banks, both in all kinds of shapes and sizes, can play a role, but it's most importantly a role for the private sector and for the governments to have a long-term policy. And I think the pandemic has tested some of the national health systems of different countries, especially investments that have been made some 50, 40 years ago, not only in the infrastructure, not only in the networks, but also in the professionals that are now being able to operate at full scale. So I believe that we should couple the public policy and the technological solutions, many of which can reduce the costs and ameliorate the type of sophisticated tests that can be offered here. And this is, I think there is room here for private and public cooperation if we put this as a priority for our national governments, but also for the international cooperation.
Thank you very much. Very important to advocate harnessing the power of technology and the digital revolution there in health, and that's something that Neelam had touched on. So Neelam, your closing remarks really on, you've got to tackle so many things at once when you're talking about trying to achieve universal health coverage and good health systems.
Well, I just want to agree with everything that Natalie and Sergio have said on the importance of the role that governments can play. And I want to mention that at least in India, a serious illness in a family is the leading cause of it falling back into poverty, even when they've managed to pull themselves out of it. And very briefly, I just want to mention that Bangladesh, which was declared a basket case when it first became independent, has actually dealt with many of these issues really very productively. Two large NGOs, Grameen Bank and BRAC, have mediated the health and employment issues and women's empowerment to the extent that Bangladesh now has better statistics in health and child and female mortality than any other country in South Asia, including India. It has also now a higher per capita income than India has. And we should look at the examples of developing countries, of countries amongst ourselves who have been able to deal with these issues in better ways. Thank you.
Thank you so much indeed, Neelam. And thank you to you too, Natalie and Sergio. Been fascinating listening to you all, bringing your own perspectives from your own regions in the world. I think that you've given us all food for thought, and really I think we've tackled this question of public health imperatives in the global south in a challenging recovery extremely well. I think that we've highlighted what needs to be done to tackle this current pandemic, try to prevent the next one, and also at the same time how it's put the focus on making sure that we have robust and resilient healthcare systems to really provide universal health coverage for everybody all over the world. Thank you so much indeed. I've thoroughly enjoyed being with you. Thank you to the Policy Centre for the New South, and we hope that next year, as Sergio said, we'll all be meeting in Morocco. So all roads lead to Morocco. Thank you so much indeed for listening to this webinar. From me, Zainab Badawi in London, and from all of you, my panelists in London, Brazil, and India, but kind of via New York, as it were. Thank you very much indeed, Neelam Dio, Natalie Delapalme, and Sergio Suchodolski. Bye.
Thank you very much. Thank you. Thank you.